What the is that? Whatever we want to talk about, we're going to talk about it. What's up, guys? Welcome to another episode of the E4 Explicit podcast. And today I have Rebecca Katz, PhD, right?
Yeah.
PhD, okay. So you're
got one of those.
Yeah. So you have a lot of degrees. We're at Georgetown Medical Center. We're right next to it.
No, we are in the Georgetown University Medical Center right now.
Okay, good. So I walked up a steep hill to get here, and my calves are burning. So it is what it is. But so you're a professor here.
I am.
Okay. And I met you a couple weeks ago. I was filming, and you did a testimonial for me, and I overheard you talking to someone about Ebola, and I'm like, what the hell? Like, what is she doing? And then so I talked to you, and you were like, yeah, I'm a researcher scientist, a professor, whatever, at Georgetown, and I focus on these terrifying diseases. And I'm like, okay, well, we got to talk. So now here we are. So kind of give me a little bit of a background on yourself.
Who am I?
Who you are. Yeah. Who's
All right,
Rebecca
fair
Katz?
enough. So as you said, I'm a professor here at Georgetown,
Mm-hmm.
and I direct the Center for Global Health Science and Security, which is a multidisciplinary research center that focuses on really kind of the policies and practices for preventing, detecting, and responding to public health emergencies. So kind of these scary diseases. And so I do that, and I can tell you a little bit about the work that we do here at the center, and what, who we are, what we are about. And I also teach, and actually most of my teaching is in the School of Foreign Service. So I teach a course on global health diplomacy, on emerging infectious diseases, and then health security.
Jesus. Okay. So you literally live and breathe these, like, everything about how to find, how to research, how to contract these diseases. Like what? Like,
so kind of. I'm an epidemiologist by training.
Okay.
So I'm not a clinician. I don't treat patients.
Got it.
And at the core, what we do here is we do policy. So we apply all of our background knowledge. So we have people who are microbiologists and virologists and disease ecologists and lawyers, and I'm kind of our resident social scientist. Wow. And we apply that knowledge to thinking about the policies and practices for preventing, detecting, and responding to these infectious diseases. So whether that is, does your country have an effective laws in place, or is it? Do you have a policy? Do you have a way to move samples from one part of your country to another? Do you have a disease surveillance system? Do you have networks to talk to each other? Are you, what kind of, do you have the capacities you need to be able to effectively respond if you have a public health emergency?
Jesus. So you don't really focus on the U.S., right? Because we, I guess, technically got our stuff together in certain way.
I mean, I think... Yeah. I used to do a lot of work on domestic, we call it public health preparedness.
Sure.
I do much less of that now, but when we talk about global health, we truly mean global, so it's domestic and international. Got
it. Okay. So what's like the main, or some of the main diseases that you kind of cover, or you let people know, like, hey,
So, I mean, I have to say a lot of our work is not necessarily disease specific. It's we'll look at, the flow of money for all diseases and this, but I can kind of cheat a little bit on your answer because the World Health Organization has a couple of lists that they use. And so I mostly agree with them. Yeah. And we mostly use those to think about what are the major diseases that we're following that we care about. They have two lists. Two lists worth mentioning. One is that the kind of the top global health threats for 2019, which is a little bit broader than infectious diseases. So that includes things like vaccine hesitancy and non-communicable diseases. And then they also have something that they call the R&D blueprint so what they think are the priority diseases for research and development. Like, what do we desperately need vaccines for? Sure. And there's a list of 10. So that includes Nipah virus. So that's like the virus that the movie Contagion was modeled after. Mm-hmm. It includes Lassa, so some of the hemorrhagic diseases like Ebola and Lassa and Marburg. MERS, wow. So Middle East Respiratory Syndrome. So kind of the cousin of SARS.
SARS, yeah.
It also includes something called that they call disease X, and that's supposed to be the placeholder for any emerging infectious disease that might pop up, because we know that that's going to happen. And we
Disease X?
Yeah, that's what they call
terrifying.
it, disease X. But it's a great placeholder because we have, there's been approximately one new disease emerges every year for at least the last 100 years. And we've seen a 4-fold increase in the number of those new diseases emerging over the last couple of decades. And some of them are not a big deal. Some of them are a big deal.
Sure.
So it's kind of keeping track of what is that next big thing going to be, what it's going to look like, how do we detect it, how do we respond to it if we don't even know what it is.
Sure. Yeah. Like, how do you even, if you know a new disease comes out every year, basically, how do you prepare for something that you don't even know what it's going to do?
Right. So you prepare for it by having as healthy a population as you possibly can have.
Sure.
Right. So if your population is completely malnourished and not able to fight off infection,
Sure.
They're going to be worse off.
Of
So
course.
having a relatively healthy population, having those people have access to care. So if they get sick, it doesn't brew somewhere for a while. Like
Sure.
they actually can get
They
in
can
to
get
seek
back
clinical
to-
care. Somebody can figure out what's going on. To have a system in place for surveillance. So if a clinician sees something weird in a village somewhere, they can report it to somebody, and that somebody can take data from a bunch of different villages and make sense of it. So it's not like one-off. So you can figure out something going on as fast as possible. That you then have, we call them rapid response teams, RRTs. So if you have an indication that something weird's going on, and you have laboratories that can quickly rule out that it's not malaria.
Yeah.
Right. So, and you have those kind of that infrastructure in place, then you ideally have a team that can investigate, and they can start doing, the true epidemiology and investigations that you would do for any outbreak. So, the who, what, where, when, why, and that, you would have the capacity to then know when you need to call in help, and that we would ideally get to a point where we have diagnostic platforms where one test can rule out a whole bunch of things.
Oh, wow.
Or we're not quite there yet.
You don't have that yet? No?
we're getting there.
Okay.
Or you get to a point where you have a broad spectrum antibiotic where, it's a drug that
Covers a lot of
covers
stuff.
a bunch of stuff.
Yeah.
Or that you have such good R&D in place that you can, quickly identify what your new agent is and come up with what we call a medical countermeasure, so a drug or vaccine. And not even that, but you would also then have the infrastructure in place to manufacture it for enough people in the world that would need it.
Like right there.
Right there and then also distribute it, because keeping cold chain, keeping something cold, and getting from a lab bench where I'm like, I think I've come up with a solution, to actually getting a shot into
A person.
7 billion arms is a logistical nightmare. So putting all those processes in place helps you then address the thing you don't know about.
That's insane. That sounds so much.
There's a lot.
That's a lot.
Everything's a lot. So even just thinking, domestically, if you go to an emergency room on any given Tuesday,
Yeah.
you're probably gonna have to wait a while.
Yeah.
Especially if you're coming in with a broken leg. So
Yeah.
something non-life threatening. You're gonna sit there for a couple hours if you're lucky.
Yeah.
So now imagine an event where a couple hundred or a couple thousand people show up at your emergency department.
That's
So
terrifying. With
how do
stuff
you-
that you don't know.
Or even something you do know, but some event happens. How do you think about that? What kind of infrastructure do you have in place for surge capacity?
Well, that happens all the time with mass shootings here. Every time I watch a documentary or see a video about when they interview the hospital people, they're like, they had to send 20 people to that hospital, 10 people, and then they got people laying in. It's like a episode from Grey's Anatomy. It's insane.
Right. But somebody has come up with a plan for thinking about that.
Yes.
Somebody has come up with and exercised
Got
it.
it.
Somebody has thought about, the hospital is right behind me. We don't physically have enough space. Where would you physically put people?
Yeah.
Would you call in the med students from this building
To
to help out?
Yeah.
How? But you have to you can't just do all that on the fly. You have to actually think about
Yeah.
all that. Even thinking about, if there was some type of event where we had to get, like scaremonger, but let's say that there was some event where like everybody in Washington D.C. was exposed to anthrax.
Sure.
You can treat that, right? But you have to get treatment to the population in a certain period of time.
Really?
So even thinking about, some every disease is a little bit different, but sometimes you can do, post-exposure treatment. So you may have like a 3-day window where you could, get certain antibiotic into somebody. But how do you do that? What are the logistics behind that? Is it, and there's been a lot of different experiments with how you would manage responding like that to a massive event. Whether it's pre-positioning drugs with people, whether it is, setting up all your big box stores that they would be distribution sites, whether you're driving through McDonald's, you stick out your arm, you get your vaccine, you keep driving.
They thought of that?
Lots of things have been
That's
exercised.
insane.
And in fact, it used to be the policy that under Obama, there was an executive order that was an agreement with the post office. So the post office would like come and deliver your Cipro to your house. That's not in place right now, and I don't really know what has come in place instead of it. But
Do you think that was a good idea?
I think it's an idea,
And anything is better than nothing.
right?
Yeah.
So, and I think that's a challenge. There's no perfect solution to any of this, but a lot of the times it's just having sat down and figured out what are our options and what can we do.
That's insane. Are you a fan of the flu vaccine? Do you get your flu vaccine every year?
Never miss it.
I bet you don't.
Never miss every. So
I
I'd say.
don't remember last time I got a flu vaccine.
So when I teach, the two things I tell my students, if they take nothing else away from my classes, it's get vaccinated. I used to just say just for flu, but now I'm like, just please get all your childhood vaccinations as well. So get your annual flu vaccine and stay away from bats. That's
what?
Bats.
Oh,
Those are like
bats.
that's my two like nuggets of wisdom
Why?
that I share.
Like vampire bats?
No, like fruit bats. They carry a lot of nasty diseases.
Really?
So
Interesting.
We think that the West Africa Ebola outbreak actually started by a 2-year-old boy playing with bats in his backyard.
What?
Yeah, because
my
all
God.
these emerging infectious diseases, somewhere in the realm of like 60 to 70% of them are zoonotic, which means that they're diseases in animals that are jumping into humans.
Sure. Makes sense.
Right. So the majority, and Ebola,
And that won't kill the animal?
MERS, sometimes it does, sometimes it doesn't. It depends on the pathogen,
Got
and
it.
it depends on the animal. So like avian influenza, bird flu.
Mm-hmm.
There were chickens who were getting it and getting sick and dying, but like the wild geese and the ducks were fine. So it really depends. But yeah, so Ebola West Africa, the theory is that it was species jump from bats to people.
That's I have a crazy story about that. So that happened in, I think, beginning of 2014 was the breakout.
It started December 2013. Yeah.
So that's when I was in Africa in December 2013 filming a documentary, and like it's so weird. So when I got my vaccination I got yellow fever, I got malaria. Well, no, I didn't get my malaria.
Yeah, it's pills for malaria.
Pills.
Yeah.
Let me tell you, I stopped taking them maybe day 2 or day 3 when I was in Africa, because I
Weird
was
nightmares.
like,
No.
no, but you know what? It's weird. My second day there, I went to Sierra Leone, and so like I didn't see any cows anywhere, and I just saw a bunch of dogs and like goats and stuff.
Mm-hmm.
And I ordered a burger the first night I was there, so I didn't know what it was, whatever. The next day, I was like tremendously sick. Like I was throwing up. I didn't know if my body was just like reacting to like a new environment. Completely different climate, completely different, just totally different than here in DC. So it was weird. And then I was like, the next day after that, because I was there for like 30 days, the next day I was fine, and I was like, I was really on it, taking my pills. I'm like, it's got to be because I hope I don't get like malaria or something. So then I was fine. After that, I had a blast. Like I was never sick.
You got over.
Yeah, I was like, I'm good. I'm like, it's insane.
But there's a lot of stuff out there.
Sure.
I mean, my story in 1995, I was living in southern India, and I was working in maternal child health clinics.
Wow.
And I got super sick.
Really?
Yeah, nobody could figure out what it was. So yeah, it took it. I ended up coming back home, and
Sick?
then took another 8 months to figure it out. But it turns out the bug I caught was it's a disease that's endemic in the region, so it's not unusual to see it.
People get it and they get over it probably.
Yeah, and I got the goat version, so it was either from like infected milk in my coffee or just airborne.
Holy crap.
Right, so you never know.
That's the reason why I brought that up, was because I thought it was weird, because I would watch like Al Jazeera because I didn't get CNN, and I'm like, why is everybody in America freaking out right now about this Ebola breakout, right? And I'm literally here.
You're there.
No one's even talking about it. It's like it's like when someone gets the cold here. Oh, that person in the office, if someone got sick here with a cold, everyone wouldn't be like, oh, like, that's how I kind of compared it. It was so weird. And I'm thinking
well, how weird, I mean, even weirder for, a lot of the coverage and even like the signs when you come back to States with, have you been to Africa? I'm like, well, Africa's a pretty big place.
You're right. It's, yeah.
So, have I been in Guinea? Maybe,
yes.
Have I been in have
I
been in Conakry in Guinea?
Yeah.
But,
wow.
Yeah, it's always, I mean, as outbreak goes, there were over 22,000 people who got sick, over 11,000 people who died.
In Africa.
In West Africa.
That's a massive amount of people.
Huge outbreak. But 22,000 people in countries with millions.
Yeah.
Right? It's you might not see it or live it.
Sure.
So even imagine if you're in like Kenya and somebody says, "Oh, you're in Africa, you have Ebola." I'm like, no. It's like
literally. Yeah.
Yeah.
Completely not even close. And that's the thing, is like, when I got back, everyone was like, "Oh my God," freaking out. And I'm thinking like first off, I was in like Sierra Leone in West Africa, where it didn't even happen even remotely close. It wasn't in Sierra Leone. It was in
well, it was.
It got to.
It might not have been there when you were
yes,
there.
It got to Sierra Leone after I left, but it wasn't even, and it wasn't even like, it was almost like a common thing almost. Not to that extent of like of a breakout, but it was like, oh, it wasn't a big deal. But whereas Americans are like, the world is ending.
But it also, I mean, that's a communication challenge too, right?
Sure.
So you might have been in a community that was like, oh, it's no big deal. There's
Sure.
like a case here. But in order to contain it, it required a lot of behavioral modification that everybody has to do.
Got it.
Right? So by 2016, nobody was like hugging and kissing anymore. Everyone just kind of did the elbow shake.
In Africa.
In the areas where the affected countries were, right?
Jesus.
So in Liberia, Sierra Leone, and
Yep.
Guinea. One of the huge challenges was changing burial practices, because traditionally, when somebody dies, you wash the bodies and people touch the bodies,
kiss
and
'em.
that's how the disease was spreading. And so how do you...
someone would die with Ebola, they would have a funeral, they would
and
kiss them
everybody
and hug
would
them and wash them.
exactly, and
Holy
that's
crap.
so like one person's death was causing lots of people were getting sick from one
Jesus.
funeral. But if you're not seeing it and living it, having somebody come and say, hey, you need to change your traditional burial practices
Like,
because there's this, right. I mean, it took a lot of effort, and it was, it's why actually, we talked about all the kind of the logistics and capacity for responding to outbreaks, but a lot of times it's building a level of trust with the population that's impacted, understanding their perspectives.
Yeah.
And because often to mitigate an outbreak, people have to change what they're doing.
Of course.
But they're not going to do that unless they, who are you?
Yeah.
What are
You're
you
just
saying to
coming in.
me? Is
Cultural
this really a
differences.
problem I
Yeah.
have? So they have to understand, they have to actually understand that this is something they should care about.
Yeah.
And you have to be a trusted broker and respect kind of their positions and figure out how to work with the communities. And sometimes people forget to do that.
Yeah. So would you say that like because I remember it wasn't right after the outbreak, or was it? It was when someone came to Maryland that was infected with Ebola from Africa. Is that something that, like, if that person came here, they could have, like, infected, like, thousands of us?
So there were a couple of cases of Ebola in the United States of people who came back into the came into the country having been in West Africa. There were also a couple of cases scattered throughout Europe too.
Wow.
The way Ebola spreads is it's by bodily fluid.
Sure.
So you walk down the hall, you're not going to get Ebola
airborne
from anybody.
Yeah.
Now, if you're, if you are in contact with somebody, you touch their sweat or their blood, or somebody throws up on you, that's a totally different deal,
that's
right?
Never a good thing anyway.
Never a good thing. So, and also we are fortunate that we live in a country that has a really good healthcare system.
Sure.
And our hospitals have gloves, and they have they have basic personal protective equipment. Sure. Still, if you're like the nurse taking care of somebody and somebody throws up on there's a lot more opportunity to become infected. So I don't think anybody ever expected that we would see thousands of cases here, but I think there was people were prepared, public health officials were prepared to see a couple of kind of family clusters, or a healthcare worker who wasn't able to take full precaution.
But to your point earlier, to have those systems in place where, like, they were prepared for something like that to happen. If, God forbid, it was going to happen, we would have had something. Because I remember they quarantined this guy.
Yeah. There were a lot of people who...
Yeah, they literally... Nope. Like, you're going over here. You're not coming in contact, right? Like, they were, like, very... like thorough.
Well, actually what happened was, so every state had a slightly different process, but we had folks from our team who were going back and forth to West Africa and living in DC, Maryland, and Virginia. So we had all, every jurisdiction
to deal with.
But so everybody was given a phone and a thermometer, and you folks were reporting their you had to kind of self-monitor if you were low risk, right? So you didn't come back and say, hey, nobody threw up on me and I wasn't treating patients. If you were just told to monitor yourself, and if you had a spike in temperature, then you had to report it, and so you had to again, different jurisdictions did differently. Some people were like putting their daily temperatures on a website. Some people got a phone call every day. Wow. And that was if anybody had spiked a temperature, if anybody looked like they were getting sick, then absolutely they would have been isolated. Wow. And that was how it was usually managed. Some people were put in quarantine, and then there was a lot of really interesting debate about what our quarantine policies are in the United States.
Because you see in the movies all the time, it's like these hazmat suits and like all this crazy stuff, like in Contagion. That was insane.
It's all scary, right? And quarantine by definition is kind of scary, right? So the idea with quarantine, so somebody knocks on this door and says, hey, you guys have been exposed to something. Sure. And all right, so we're going to keep you in this room and we're going to lock the door and you can't leave.
Okay.
And we're looking at each other and we're like, all right, that's fine. I got some work to do.
Yeah.
Hang out.
Figure it out.
Couple hours in, we're we start like looking at each other a little funny and so what did you do? Yeah. Who were you exposed to? You start to kind of turn on each other a little bit.
Yeah.
Or it's 6 o'clock at night. I want to go home. I want dinner. I'm getting annoyed.
Yeah.
Quarantine is the worst. Like, nobody wants to be quarantined.
Yeah.
But and there's all sorts of things you can do to make it better, right? So like, if somebody left us in here to our own devices and said, you're it, that's one thing. If they came and delivered us food and
made it nice.
Brought us some phones,
yeah.
And,
yeah.
we got to Skype with people.
Yeah. Got stuff done.
That would, so there's ways to make it, or, here's $10 for your worries.
Sure. Thanks.
It's nobody wants to do it, but when you have an outbreak and you don't have a treatment, it's one of the tools in the public health toolbox. So it's one of the things you can actually do to mitigate an outbreak.
Got it.
But it's not so hot for civil liberties. There's a lot of different ways to do it. So there's a big difference between somebody knocking on the door and saying, hey, you guys have to be in here, can't leave, and we go, okay, we want to make sure nobody else gets sick, so we're going to do this. That's different than putting an armed guard outside.
Not letting us in
and
out.
And so that's what's been done in the past. So, treating people like criminals because they might have been exposed to a disease doesn't really go over very well.
Sure.
But, sometimes you end up treating people like criminals because they get anxious and they wonder. And then 3 days in, we're sitting here, we can't stare at each other anymore. We're doing everything we can to break down the door.
Yeah.
Right? So
that would suck.
It totally sucks. But it's a tool.
Is it effective?
It sometimes.
Like if you have to use it, it's for a reason. It's a good reason.
If you have to use it, it's for a reason.
Got it.
But there's not a great evidence base for when it's effective. But it's been used, centuries.
Yeah, no, it's definitely
I mean, it's a physical stop, right? So
Yeah.
if we're the only people exposed to the disease, and they don't let us outside this room, then nobody else outside this room is going to be exposed to the disease.
Damn. Yeah, so it's...
On the other hand, it's not terribly effective if, yes, we've been exposed and we're being quarantined, but 30 other people are roaming around the hall and they've been exposed. And
sure. Then it's obviously not going to work or be effective. Got it. Okay. So are you a fan of... I know you said you tell everyone to get their childhood vaccines and stuff like that because, for instance, my little sister, she lives in Ojai, California. And
Okay.
she's not a hippie, but she has very holistic viewpoints and
Fair
stuff
enough.
like that, which I think actually her and my nephew's father, they might have recently in the past year or two got him vaccinated because they had they first were on the same page with it, and then he was like, let's get him vaccinated. I don't know if they did or not, but it would kill me because I'm like, oh, well, we're just gonna get a note for him to go to public school, and I'm like, he can't play sports, he can't do any of those things given a fair chance. I know, yeah, you're cringing, but it's I get it, but it's doesn't that affect, because correct me if I'm wrong, if one kid in a group of 20 are not vaccinated, that makes the group weaker.
Yes.
No? Okay. All right. So you
Yeah.
can elaborate.
It's called herd immunity.
Got it.
So a lot of the vaccines that we give people aren't 100% effective. And so their effectiveness is derived from the fact that everybody has it.
And they work together.
Exactly. Yes. There is unfortunately a lot of there's a lot of reasons that people are hesitant to become vaccinated.
Sure.
And for different vaccines. There's also a lot of misinformation, unfortunately.
Yeah, like the autism thing. There's never been an effective research. There's never been any evidence or research that is a contributor to autism.
There was bad research that was put out, and that was then discredited.
Yeah, and there's thousands of websites and stuff on social media that are putting out misinformation that are scaring people.
Yes. And again, as mentioned, public health has a communication problem. That's one of them, is trying to, how do you deal with misinformation?
Yeah.
And how to make sure that, you effectively communicate the importance of vaccines to populations who aren't sure about them.
Yeah.
But, oh my gosh, please, get vaccinated. Measles right now is, so, basically measles had been eliminated from the United States, and we are now seeing thousands of cases because of communities who are not vaccinating.
Yep. There's a book on Amazon called something in her measles, it's like a kid's book about this person is saying that measles is good for them because it's something crazy, and I'm like, what the hell?
So let me tell you the craziest thing. So yes, there are a lot of people who there are some people who are like, well, my mom or grandmother had measles and they were fine, they just had a rash and they were okay. Mm-hmm. For some people get extraordinarily ill.
Sure.
Some people die, and there's some crazy recent research that's come out that measles does something. So if you get it naturally, yes, you'll develop immunity going for it, but it does almost like a Control-Alt-Delete on the memory of your immune system.
What?
So if you are if you are living somewhere where you've had malaria and you've had all sorts of other stuff and you've built up immunity to some diseases over time, and then you get measles, it actually, your body like forgets, not 100%, but forgets about your immunity.
Wow.
So you have that, you're then open up to get sick from a whole bunch of other stuff.
Oh my God.
Yeah, it's insane, and I'm not sure. Like, it's evolving research on this. So some people are like, oh, you start from scratch. Some people are like, well, it's like 3 to 5 years of, your immune system like not being as effective as it used to be.
Oh my God.
But no matter what
Regardless,
it is, it's insane.
That's insane. Yeah. Regardless, that's terrifying that all the stuff that you've built up over, I'm 31, all these years could be just gone, Now, like, but the diseases that are coming back, I mean, polio is like, what? Like,
well, polio is massive effort by international organizations to eliminate polio, and so you can do this. So I talked about diseases that live in animals. If you have a disease that lives in animals, it's almost impossible to totally get rid of it, right? Because it's jumping back and forth between species. So when we look at diseases that are just in humans, like smallpox, we were able to eradicate because it's only in humans. And there was a vaccine, so there was a way to do it. Polio was one of these. So there was this massive effort. Rotary International led this effort, and they worked with Gates Foundation and a bunch of other organizations.
Gates Foundation,
and like, we're going to get rid of polio. And the curves, it used to be, thousands and thousands of cases, and then down to, by 2013, like only a handful of cases around the world.
Yeah.
Problem was that those handful of cases were mostly in kind of ungoverned spaces.
Sure.
So like the tribal region in Afghanistan, Pakistan, northern Nigeria, places
Congo.
where there was instability.
Sure.
So you couldn't do the massive vaccination campaigns. And because of that, the disease has popped up, and then it's now like there's a bit of a resurgence of cases around the world. Again, mostly in these difficult to reach areas.
So these aren't from like people not getting their children vaccinated.
No.
Interesting.
No. It might be, because you can't get vaccinated in wherever you happen to be in the mountain, in the Hindu Kush.
Yeah.
Right.
Yeah. Good luck.
Well, and also, there were polio vaccine workers who were targeted and assassinated, and
what? Back up. What do you mean?
So, it's a challenging space. There were a couple of things going on. One, when Osama bin Laden was captured and killed, they wanted to make sure that they had DNA proof that it was Osama bin Laden.
Sure.
So there was an effort. There was like a fake immunization, like a doctor who knocked on the door and like swabbed the kids in the house to get part of this DNA effort. But it was all like hidden behind an immunization campaign. So that immediately put kind of a target mark on the back of polio vaccinators working in Pakistan.
What?
And which are unfortunately mostly like young women.
Yeah.
So there were a bunch of young women who were assassinated, who were doing vaccine work. Also,
why did they blame those polio?
Because it was like a CIA effort to like a doctor who they pretended to be doing a public health campaign, right, to get the DNA to prove that it was Osama bin Laden.
So they were like, oh, these ladies are doing this, blah blah blah.
It just kind of it became really bad PR for them, and then there's been a lot of misinformation around the world. At one point, there was accusations that these vaccination campaigns were efforts to sterilize Muslim children. So people put stuff out there, and if it gets picked up enough,
clickbait,
right? So it's been a challenge in some places to get over misinformation and to prove this will save your kid.
So how frustrating is that as someone who lives and breathes this stuff, that literally has done the research, seen the research, done all that stuff, and then you see like some bozo website or some bozo link on Facebook that says autism links to, vaccinations, and you're literally like, but see, that's the thing. The people are not taking the time to read those articles.
But, so let me put it a different way. I'm a public health professor.
Yeah.
So my job is to make sure the public understands health, right?
Yeah, exactly, yeah.
So I see that, and I'm like, well, we're not doing a good enough job.
Yeah.
So we need to get better about our communication strategies, about making sure that people are able to differentiate good information from bad information, about having trusted resources.
But how?
It could be all sorts of things, right? So there's now an effort by, even the way, if you go onto Amazon, the way that they categorize the material on there.
Yeah.
So, something that's like, that I would think is complete misinformation, you don't categorize it under like health and medicine books.
That's the thing. That's the thing that's scary is, first off, Amazon doesn't even, with the books and stuff, they don't have a system to where they can, if you wrote a book and I wrote a book and I'm just making up stuff, they're not going to say, oh, this person, they're not going to do their research on me. You know what I mean? Which is unfortunate, because that just makes your guys' job 10 times harder, because you're going against people that don't know what they're talking about. They just want to sell a book or get some clicks or do this or do that. And that's scary.
Yeah. So we got to be better. Yeah. So as much as I hate, doing anything that involves a camera, I'm going to go sit and talk to you about stuff for a while. Right. Yeah. And then you have to have conversations with groups like Amazon to say, okay, I know this isn't your job, but if you think about, what small things could you do that don't infringe on anybody's ability to, participate in the free market.
Yeah.
But also don't inadvertently endorse something.
Yeah. Don't lump all of these things together that, like you said.
And I think folks, when they realize what's going on, are open to having those discussions.
Sure.
Now, what they can and can't do and still, maintain their platforms.
Yeah.
It's not my space.
That just sucks, because that, like I was telling you earlier, I was listening to the podcast on Joe Rogan, and he had literally the conversation we're having right now is the same exact conversation he had with this gentleman who wrote a book, and he was like sponsoring his book, but he was saying on Amazon, he's like, there's 15 other people ahead of me on Amazon, and all of them are like bogus, like they're not even legit like researchers or anything. And he's just like, it kills him, because he's like, Amazon's not gonna like sit there and put someone in charge of like vetting these people,
or the internet,
right? Yeah, it's just, there's so much, I guess, fake news as far as, if you want to call it that, out there about this kind of stuff. And it's scary, because like my sister, like, first off, I don't want her to like make a decision like now thinking from like a couple people's opinions that don't know what they're talking about to affect my nephew's life, unfortunately, for the rest of his life.
It's hard, right? Even as knowing what I know, I remember bringing my kids in when they were infants to get their vaccines.
And you're like, what the hell is this?
Oh my gosh! Like, I know this is fine, but like, it's still hard.
Yeah.
They're crying. They might get a fever for a couple of days. There are adverse reactions to vaccines. It does happen.
Yeah.
I think it's, we can't pretend that it doesn't.
Yeah. It's a small percentage.
It's just very small, and you can pull up the accurate numbers. Mm-hmm. Actually, Hopkins has a vaccine, a center that studies this, that puts out really excellent data. But so yes, it's hard, but I it's part of living in society.
Yeah.
If you're a parent, your kid, you want to live on a farm and not interact with people, you do whatever you want.
Yeah.
If you want to live in a city and be around people all day, then I think you have an obligation to do what you have to do to be part of that protected population.
I agree. And I think it's like, but to your point, like if my sister lived in a farm in the middle of nowhere, no, she lives
do whatever you want.
45 minutes away from Los Angeles, California. So like a major metropolitan city. And
I had a cousin who delayed vaccination of his kids living on the Upper West Side. Drove me crazy.
That's insane.
I didn't talk to him for a couple of years.
Yeah, no, and that's what scares me is like, it's not just her. It's like in Ojai, they're very like they're everyone is like that. Mm-hmm. It's not just like, and there's a lot of people like that on the West Coast that are just like more laid back and this and that, and or think a certain way. So like when you have those clusters of people, like you said earlier, if a giant cluster of people don't do that, that's going to affect even larger cluster of people around them, right?
It's why we're seeing large outbreaks in Orthodox Jewish communities in New York right now.
Oh.
Because
of measles.
Because you have measles, because you're having communities that are kind of reinforcing each other.
Wow.
And then you get one infected kid, and then they all get sick. Measles is insanely contagious. We talked about Ebola like not actually being that contagious.
Well, that's airborne, isn't it? Isn't measles airborne?
Yeah. So Ebola, there's something in epidemiology called the R0, which is the reproductive rate.
Okay.
So it tries to kind of average out, like, for every person that gets sick, how many people they get sick.
Okay.
So for Ebola, it's maybe 1.
Wow.
Sometimes less.
So if I'm sick, I might get one.
You
person
might get
sick.
one person sick.
Okay, that's
It's not
good.
so bad, right? And if you have a R0 of less than 1, if you can do the thinking on that, your outbreak's going to die out.
Sure.
Influenza, we're like, it maybe have an R0 like up to 3.
Yeah.
Like you might get 3 people sick.
Interesting.
You're sneezing and coughing all over
I would think
everybody.
that's more.
Yeah.
Because if it's like a projectile, like,
Measles, 14, 15.
What?
It is so incredibly contagious.
Oh my God.
In fact, if somebody with measles had been in this office 2 hours before, the virus is still in here. We could get infected, 2 hours after somebody has left.
It's just floating around.
Yeah. I mean, it is insanely contagious, which is why, it's a huge problem in urban areas, right? Because it's
so many people.
So many people.
That's insane.
Yeah.
So like the side effects of measles doesn't it affect you mentally? No.
It can be a complication. You can have like an encephalitis as a complication.
Wow.
Yeah.
And how do you die from it? Because I know a lot of people say, it's just
You're
a rash.
not going to die from a rash, but you'll die from the complications.
Interesting.
Yeah.
If it's not treated. But if you
I
have
think
it,
even it, like it, again, I'm not a clinician, so
no.
I don't know. But it's it becomes these complications. It's not necessarily related to whether you're treated or not, but just the course of the bug in the virus in your body.
Wow. Have you heard? This is a total sidetrack. Have you heard of Are you familiar with parasites at all?
Yeah, I know a little bit about them. Yeah.
So have you heard about the parasites that control minds?
No.
There's ones. I forget what it is. There's this little worm parasite that gets into a grasshopper. They only go after grasshoppers.
Okay.
It goes into a grasshopper, and it makes it commit suicide by jumping and drowning in water.
It's like every bad. I can see the zombie apocalypse.
That's terrifying.
Yeah.
Yeah. I'm like, but there's like other parasites too that like do that, like literally mind control their host. Once again, I heard it on the podcast.
I heard it, therefore it's true.
It's real. No, but these are like people like you that like literally do these research. That's fucking crazy. So, the measles? That's from the animals, right?
Yeah, I don't want to go into measles. I don't know it well enough.
Yeah. What are these from?
But no, it's not. It's not a disease in animals. Measles is just in humans, which is why we were able to
have a vaccine for it.
Yeah. You can have vaccines for we have a vaccine for Ebola that seems to be incredibly effective.
Really?
Yeah, it's an experimental vaccine. It's gone into over 130,000 people right now. There's an outbreak going on right now in the DRC.
Oh.
Yeah, it's really bad.
Really?
Yeah, I'm sorry. I'm going off of measles, but
no, you're fine.
The DRC outbreak is worth talking about.
Sure. DRC, explain.
So the Democratic Republic of Congo?
Yep.
Yeah.
That's kind
and it's in the outbreak that's happening right now has been going on almost a year in the northeast area of the country. So right near like the Uganda-Rwanda border. There have been over 2,000 cases already.
Jesus.
Even though there's there is an experimental vaccine that Merck produces that has gone into over 130,000 arms. So
in the DRC.
In the DRC as well as in like the surrounding regions and first responders. So even though they've been vaccinating people, there's still over 2,000 people have gotten it. And the real challenge in this particular outbreak is this region of the world is there's a lot of conflict.
Yeah.
So it's ungoverned. The national government really doesn't have control. There's a lot of different armed militias that are operating. And it is a really, really hard place to work. So there have been Ebola responders who have been targeted and killed. Last week, a lab was broken into, and they stole all the computers and a very expensive piece of equipment to do diagnostic testing, which nobody else would be able to use except it was used for diagnostic testing. Ebola treatment units were burned down. So it makes it really hard to operate. The normal strategy that you do to vaccinate for an outbreak like this is something called ring vaccination, which would be, if you were sick, then, I would get vaccinated, and then like my family would get vaccinated, and then a ring around my family would get vaccinated, and you kind of build out in rings and rings and rings. But because they go in and it's such an unstable environment, they don't have time to do that type of ring vaccination.
Yeah,
so they do instead all right, we're just going to get the whole village as fast as we can in the hour we've got before the militias return. Right. So it's really complicated.
Why do people not want this outbreak to stop?
It's not about that. I mean, the rebels don't want Ebola either, right?
Yeah, right.
I think it's about, I think this, again, not an expert in this part of the world, but my understanding is this is a region that has had so much conflict that there's not a lot of trust for officials.
Sure.
So who is this person? Who are these folks?
So what you talked about earlier, like you have to have that trust and that relationship for people to let you come into their own place and tell them how to operate. And
it's really hard. So for public health officials, do you come in with an armed guard?
Yeah.
It's not great for your trust building.
Sure.
But if they're attacking you, you need an armed guard.
Yeah.
So, how does that work? And different organizations have different perspectives on that. Like, so Doctors Without Borders tends to not, but then 2 of their facilities were attacked and burned.
Wow.
If you go in with the UN peacekeeping force behind you, that seems pretty official. Like, so the community is not interested, and so if part of the challenge is getting the community to change their behavior or change the way they bury people, or to allow you to do a safe and dignified burial of somebody and not attack the ambulance to get the body back. It's just really, really hard.
That's insane. Now, is that people that are Americans going over there to do all this research and do all this outbreak?
This outbreak's a little bit different because it's such an insecure environment. We don't have many U.S. personnel on the ground. Wow. So there are CDC officials who are supporting the outbreak. Some of them are in Geneva working with the WHO. Some are in Uganda and Rwanda making sure that people on the border are ready and prepared. Some are in capital. But there's very few near the epicenter of the outbreak itself because it's not safe.
Too dangerous.
It's too dangerous. So instead, it's a lot of WHO staff. There's a lot of kind of south cooperation. So there's epidemiologists from Guinea who are in the DRC helping out. So it's an interesting collection of people who are incredibly dedicated, who are literally putting their lives on the line. But it doesn't have the massive influx of expats coming in to save the day because it's just not safe.
Yeah.
We think there's an important role for academia in trying to provide the evidence base for decision making, right?
And the knowledge too. You guys got to.
So we're trying, right? So one of the things that we're doing, so it's a little bit off, but I track money. So I track the amount of money that is flowing to help build capacity so countries are able to prevent, detect, and respond.
Interesting.
And in the last 10 years, a lot of money starts getting thrown at stuff, and it's thrown at certain countries for some capacity building, but not others. So we try to get our head around that and to identify the data so we can look at it. We make everything public and online and available, but then you can start doing the analysis behind it. So, is the relationship between the amount of money that the world has given to, say, Kenya to do laboratory capacity building and their actual effectiveness in responding to an outbreak? And so, you can't answer that question unless you have the data behind it. And then if it's not about the money, then what is it? And what kind of, what are the hypotheses that you then want to be testing for? Like, what are the relationships? Is it more the commitment of the government itself? Often, yes.
Yeah.
Right? So instead of just dropping money in, maybe it's more effective if you kind of work with the government to identify, like, why do they care about this? Why should they care about this? And, or to build their workforce, or to build, so there's a lot of, it's kind of boring and it's wonky and it's policy, and it has to be done,
in an office.
It has to be done in an office. Doesn't matter where in the world the office is, right?
Yeah.
But by people who don't mind going through the data and then spitting that back out and giving it back to decision makers so they can ideally make better data-driven decisions.
Of course.
And that's actually one of the reasons we're doing this conference next week in Sydney. So we've got 860 people from all over the world who are coming in to present their work on all sorts of different aspects of global health security, whether it's on antimicrobial resistance or on the role of militaries, or new lab capacity things, or new ideas for disease surveillance, or what does community-based disease surveillance look like. There's all sorts of crazy research. But the idea is to bring everybody together. So one, you know about it, because there's a lot of research we don't even know about.
Yeah.
And then also to be able to communicate that to the governments and the philanthropies and the folks that are actually making decisions and doing stuff.
Yeah. Okay. So last question.
All right.
Do you think in the future or ever there will be like one vaccine that will kind of like prevent everything? You know what I mean?
Yeah.
Like you were saying earlier, like there's some things that like.
So I don't think one for everything, but there's a lot of folks who are very much hoping that sometime in the next 10 to 20 years we have a universal flu vaccine.
That's recent.
Because if you were going to ask me what do I think is like the thing that worries me the most, influenza.
Really?
Because there's seasonal influenza. There's what you should be getting your seasonal vaccine for.
And it doesn't always match that type of flu, right?
It's not perfect, but it's getting better. You're still going to be better off if you get it.
Exactly.
But so we have the seasonal strains, and then there's pandemic strains. So these are strains that emerge every once in a while that they just have a much higher case fatality rate.
Sure.
So, the last huge one was 1918, right?
Yeah.
So that was Spanish flu.
Yeah.
Killed about 50 million people around the world, and that was before we were actually like a, connected world.
Sure. That's a lot of people.
Right. And that was when you were still traveling via, ship.
Yeah.
We now have 10 million people every single day on an airplane. So things move around the world much faster now. Our trade is interconnected. Everything's interconnected. And you get every 20, 30 years-ish, you get a strain that pops up that has a much higher fatality rate. We've had a couple of scares. So H5N1, the bird flu.
I remember that, yeah.
Right. Case fatality rate of around 50%. Now, Spanish influenza, case fatality was like 3 to 5%. So of all the people who got sick, only like not that many people died, and 50 million people died.
So imagine.
Like an influenza strain that spreads pretty easily, but kills a lot of people, and that scares. That's what I think most people in my profession are the most scared of. Actually, Bill Gates ran some models that he predicted that sometime he has this amazing team of disease modelers working for him, and his folks are telling him that it's probable that sometime in the next 10 to 15 years we will see an airborne, respiratory virus emerge that has the capacity to kill up to 30 million people in a year. And now, but he uses that to show what good preparedness and response would do. So if you were able to get a vaccine out within 6 weeks, you saved 29 million people.
Wow.
Right.
And this is the Gates Foundation, no?
Mm-hmm.
Yeah, and they've done some really incredible things.
So so that's the thing that I worry about, which is why, a universal flu vaccine would just be
ideal.
Would be game changer.
That's insane. Is it because a lot of people don't take it that serious? is what's scary about it, because it's like, oh well.
No, I think influenza like this, people would.
Well, they would, but I'm saying like the H1, the bird flu, that was like I was saying earlier about the Ebola thing. It was like, it was scary when it was like almost like in the 11th hour, people were trying to be serious about it.
Well, there's two things, right? So there's the H5N1, the bird flu, which I think people are scared about, but it never sustained human-to-human transmission. Okay. So it's kind of this scary thought, but it's not our problem yet.
Yeah, that's what I'm saying.
H1N1 was the pandemic from 2009.
Okay. Is that from pigs?
Yeah, that was the swine flu one.
Yeah, the swine flu.
And the problem there was it wasn't as severe as other strains.
Got it.
So a lot of people became complacent about it. Like, oh, I'm not going to bother getting my vaccine. I'm not going to do this. It's not that big of a deal. We're really lucky it wasn't that big of a deal. And it was a really big deal for the people who did get sick and you know, had a hard time with it. But it's really, again, it gets back to risk communication and crisis communication and what are real threats and what are things that people actually, you know, feel are real versus, you know, are.
Yeah. So get your flu vaccination.
Get your flu vaccine and don't play with bats.
Yeah.
It's all good.
All right, good. Well, thank you for doing this. I really appreciate it. And where can people find you? Are you on social media? Do you have a website?
Yes,
anything?
All of that. So our center, the website is ghss.georgetown.edu. Stands for Global Health Science and Security, Georgetown.
Yep.
And that's links to all the work we're doing and some cool online tools we have. I am on Twitter. I am Rebecca Katz 5. One of my old students set it up for me, so it's
And you're just on Twitter, you're not on Instagram or anything like that. I feel like Twitter for work. Yeah, that's the thing. That
Instagram
you can
for like, you know, fun.
Personally, yeah. Okay, good. All right. Well, once again, thank you for doing this. And
Thanks.
This was a good conversation.
Coming.
Yeah, no, absolutely. So that's it for the E4 Explicit podcast, and we'll see you next time.